That's why I choose some of the treatment options that you guys are going to see today. It's because I'm not hoping to get what I want. I know in my hands what I can do based on my experience. Of course, I'm always learning, trying to get better, but I like to be able to drive the treatment. I like the patient to know what I'm going to be able to give them, and I know that I'm going to be able to get them. There are four main diagnostic categories that we look at these patients, any patients. We go through periodontal, which is the pain. I go through biomechanics, which are the teeth. We go through function, which is a bite, and the dentofacial. I start every patient by where the teeth go in the face, with the incisor edge position of maxillocentrial incisors, and we work our way backwards. This is an article by Dr. John Kois. Dr. Kois is my greatest mentor in dentistry. I model my practice after his teachings from Seattle, and you guys will see a significant influence, his influence in my presentation today. Photography is a big thing. Every patient that comes into my office gets this series of photos. If I'm doing a full arch case or a more complex rehab case, there's additional photos we'll do, but this is a delegated procedure. I don't take the time to do it, train my staff to do it, and it takes time to stay on top of it because they can go sideways. But this is a powerful tool for me in my practice to communicate with my patients and other clinicians that are involved in the treatment. So, first thing we do, like I said, is deciding where the teeth go in the face. Everything starts with the incisor edge position of maxillary incisor teeth. That's step one. And step two is the posterior plane, which matches this step one. We set that up in the face first. Then lower incisor edge of the mandibular teeth, and then the posterior plane fall. I evaluate lip dynamic, length, fullness in the movement on every patient, and we evaluate gingival architecture and symmetry. The goal is for all these patients, these full arch patients, but really any patient, to create gingival symmetry and harmony. It's just going to look good in the face. It's just going to look right, keeping in mind patients' preferences. Where do teeth go in the face? I've tried to list a bunch of new articles for you guys. There's tons of research out there. But the one that I go to every day in my practice, at hello with every patient, is the article by Dr. Carl Misch, Journal of Prosthodontics 2008. And basically, Dr. Misch was able to show that the canine position, if you look at the canine position in repose, there's a much more acute standard of deviation, a lot less variation in length, and it's not age or gender specific. So based on that, we decide where is step one, which is where the teeth go in the face, based on the canine zero position. If you have more than 2 millimeter display, you're looking at vertical maxillary access. That's important to know because if you're looking to give a patient the smile they used to have, or you're trying to change these things, it's very important to know where your teeth are going to end up and how much bone reduction you have to do or anything else like that. Once we set the teeth in the face, on the front, then the posterior plane is just to level things in the face, so it just looks right. The upper arch, the maxillary arch, is set for aesthetics. So I decide where the teeth go in the face before I worry about anything else. I'm not worried about the lower arch. I'm not worried about occlusion yet. First and foremost, I want to make sure the aesthetics been done correctly. Then I have to wait to transform this information and transfer it to the lab or to the lab bench to be able to communicate with my technician. Obviously, Facebook, there's a traditional Facebook. I use a dentofacial analyzer, which has got laser lines. It just helps me do it. Doesn't matter how it's done as long as it's done accurately. Another really important tool that I use day to day in my practice is a platform. This is a Panodent articulators. There's many different articulating systems that have the platform built in now. This has got a little platform that I can move it up and down. And without it, I have no way of communicating with my lab. And throughout this presentation, I'm going to show you how that is. As an example, this is Kim. Let's say she has severe acid-related tooth structure loss. And once I take the photograph, this is an old case, I take a photograph and I Facebook it. When I put the platform on, it's real clear to see how it looks in the face. The step two, which is the posterior plane, is dropped down quite a bit. There's a reverse smile line on the front. So I started to work on this case. I'm starting to do my diagnostic and treatment planning work. So I decide that the posterior is a little bit too long. Those premolars in the back are too long, so I just grind them off the models a little bit. I'm able to raise up the platform. Based on that, I do some, this is me, just some light wax up incisor edges to decide where my incisor edge position is going to be based on the canine zero position that's determined by Dr. Mish. Based on that, I decide that I'm going to do some static crown lengthening. This is not a typical case that you see post-ortho with kids that we doing 2 millimeter osseous across. Every tooth has a different level of osseous reduction that's needed. I've picked tooth number 22, which is number 10, as my free gingival margin to be my point of reference that I like, and I design everything to go around it. So if you're using a periodontist or a surgeon to do this case for you, you better have this kind of a level of communication to drive the outcome. Because if you just send it to them, say level this up, believe me, they might not spend the amount of time that's required to plan this case for you the way you should. I do the surgery myself, so this is the case. I did the crown lengthening, and this is the final results. I did Emax crowns, minimal, perhaps 0.2 millimeters on the buccals, no reduction on the linguals, opening the vertical with additive procedure on the posterior mandible, and here's the final result. I have this case published in the compendium. If anybody wants to look at it, I'd be happy to share the case with you. Digital smile design. This is a concept introduced by Christian Coachman. This is basically a Facebook and a platform in a digital way. Series of photographs that you can use yourself to do the face blindness treatment planning, evaluating the smile on, or you can delegate. I use this technique for patients that I'm worried about meeting their expectations, or I want to communicate with other clinicians, specifically orthodontists. They love this. This is a patient that fell down, fractured the central two incisors, got referred to an oral surgeon, 2 implants went in, really no restorative plan, went to the restorative dentist, he's referred him to someone else. Long story short, the case kind of grew, became 2 more veneers on the laterals, 2 more canines. I've seen the results, the communication. She wanted the way wider, she signed a waiver, she didn't want to address the collapsed posterior corridor. But when the final results got done, even though the clinician did nothing wrong, went in the face, she in a hysteric fashion grabbed her temps and walked out. Left the final restoration of the bench. So I'm not touching this lady without her knowing where we can get her. So I do the photo series, we do a scan, send models. Digitally we marry these together and we're able to design the smile, and it can create a digital wax-up. This digital wax-up can be printed, and it can come with a matrix, which I can use temporary material and try it in the patient's mouth. She wants it to be way wider, I use a bleed shape temporary. Put it in, this is what it looks like if you manage a posterior corridor. Then I cut the posterior corridor out. If you don't touch it, this is what it will look like. This is as good as I can get for you. I haven't touched the patient, she still has her temps on, and then basically I'm really hesitant to do a whole bunch of veneers for her, so I'm sending her to ortho. I'm sending this information to ortho. I said, this is what we need to drive the treatment for this patient.